Dr. Bazzan and Dr. Monti spoke about estrogen replacement after menopause. I'd like to know, when do women need to stop taking estrogen? At what age, or how many years is it recommended to take it? I'm sure it's different for each person. The original report didn't talk about women who've had a hysterectomy. My gynecologist said there is pressure to take women off this hormone. Please talk about the background of this decision and how do the current doctors evaluate the criteria?
So the recommendation for stopping is 65 years old. The background was the WHI study back in 2002, where they saw that there was a slight increase in cardiovascular events and in breast cancer in women using a combination of conjugated equine estrogens, meaning horse's urine, and Premarin, pregnant male urine, and a pharmaceutical form of progesterone called progestin, which was given by the millions to women, and the pharmaceutical name is medroxyprogesterone acetate. So when, excuse me, when these results came out, everything came to a screeching halt. Now, if we fast forward 18 years after that, we found out a few things. For instance, we found out that the most responsible party for the cardiovascular problems was not the estrogen, but it was the medroxyprogesterone acetate, which is marketed with the name of Provera, which I'm sure a lot of people are familiar with that name. And also for what regards the breast cancer. Interestingly enough, when we looked at the subsequent data from the WHI, we found that there was an arm that was given 3 milligrams of Provera, Premarin, which is the horse's urine, and I'm gonna underline here by mouth, because the delivery system seems to be very important into whether we get complications or not. But for what concerns the cancer, 3 milligrams of Premarin reduced the rate of breast cancer to 23%. This is an astonishing data that not many people want to touch, because if they could do that with a drug, you know, they'd be selling it in the solar system. So, and as the years went by, we began to see how you gave the hormones was very important. And we realized that when you give them orally, you increase the clotting factor cascade. And now, if you already have a person who's obese, or is a smoker, a person that has diabetes, a person that has a tendency to clot, or they are couch potatoes, they don't move, you can see how these 1, 2, 3, 4, 5, 6, 7 risk factors gang up on each other, and eventually you end up with a bad event. Eventually, then, the menopause societies and the authorities decided that it was not a good idea. Again, you know, this is, you only see these things afterwards. You don't want to wait 13 years for a woman to go into menopause, after she's going into menopause, and then you want to bombard her with you know, very powerful hormones. Just to give you a biochemical fact, pharmacological biochemical fact. 1 milligram of Provera has the biological power of 400 milligrams of human progesterone. It's not 4 times more powerful. It's not 40 times more powerful. It's 400 times more powerful. And they were giving 5 milligrams, equal 2,000, the power of 2,000 milligrams of progesterone a day. And, you know, in our practice, we give 100. And happily, for biochemical and anatomical reasons, when you give progesterone alone, it doesn't increase your clotting factors. So you have to be in the know. And is it clear that when the hormones go away, people get older? Well, it's called menopause. I guess everybody knows that. So the question is, how do we go about helping people slow that down and keep their body composition, keep their bones, keep their muscles, keep their brain, keep their skin without running into complications? And here, I'm of the opinion that less is more. So as we go on with the years, what happens, we give less and less dose and we stretch it longer. And then with each single patient we discuss where, you know, for instance, it's very difficult, different if you have a woman that has a -4 osteoporosis versus a woman that has basically normal bones. They are very two different situations completely. So the long and short is, with paying respect to all the recommendations, in the end, it comes down to every different individual to see where they're at, what the risk factors are, what their strong points are, what their weak points, and then you make together with the patient, we make a plan.
Beautifully stated. I feel like there's such a desire on the part of women especially to simplify and to try to get, you know, one size fits all set of rules. And I appreciate how you just went through the details of how we really have to individualize this process. Mm-hmm. So, you know, this idea that we don't start hormones after age 65, I can tell you I've started them on women over the age of 65, but it's looking at a very complex situation in which I will make that decision. And it sounds like you've had a similar experience.